Recording started.
All right, ladies and gentlemen, welcome to the Presentation and Diagnosis of Alzheimer's Disease webinar. This conference is being recorded, as you just heard. My name is Jessie Mikulak. I'm with the Lewy Group. This is the first webinar in the 2016 series, Geriatric Competent Care, Caring for Individuals with Alzheimer's Disease and Related Dementias. Today's webinar is titled Presentation and Diagnosis of Alzheimer's Disease. This series is presented in conjunction with Community Catalyst and the Lewy Group and supported through the Medicare-Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. Continuing medical education and continuing education credit is available for today's webinar from the American Geriatric Society and the National Association of Social Workers. In order to receive credit, please complete the pretest located on the right-hand side of your screen by 12:20 p.m. Eastern Time. You must also participate in today's webinar and complete the post-test with a score of at least 80%, and finally complete the program evaluation form. CME and CE credit certificates will be emailed approximately 4 to 8 weeks after this event. MMCO is developing technical assistance and actionable item tools based on successful innovations and care models, such as this webinar series. To learn more about current efforts and resources, please visit our website at www.resourcesforintegratedcare.com for more details. All of the Q&As and the slides from today's presentation, as well as the recording, will be posted on that website. If you have any questions, please contact ric@lewy.com or for any additional comments that you might have. Before we get started, I'd like to remind you that all microphones will be muted throughout the presentation. There will be a brief question and answer opportunity at the end of the presentation. If you have questions you'd like to ask the speakers, please use the Q&A feature on the WebEx to submit a question at any time during today's event. At this time, I'd like to introduce our moderator. Carol Reagan is a senior advisor with Community Catalyst with over 30 years of experience with national and state-based public policy and advocacy organizations. Carol's work has included policy research, analysis, and legislative advocacy, primarily focused on health insurance coverage, programs, and services for low-income children and families, long-term care, and workforce development. Carol?
Thanks, Jessie, and welcome. On behalf of Community Catalyst and the Center for Consumer Engagement and Health Innovation, which is a project I work on at Community Catalyst, we're really pleased to moderate this session today and this whole series. Community Catalyst, for those of you who don't know, is a national consumer health advocacy organization whose mission is to organize and sustain a powerful consumer voice to ensure that all individuals and communities can influence local, state, and national decisions that affect their health. And part of our mission is to really improve the care for older adults, and thus our commitment to this work and our partnership. So we're in partnership with Lewy Group, as Jessie mentioned, and the American Geriatric Society. We've been hosting this Geriatric Competent Care series for 2 years. This year with a focus on the dementia care, given the importance of helping providers and health plans and other staff learn how to address a condition that really impacts millions of consumers and their families. It's my pleasure to introduce a group of really nationally renowned leaders in dementia care. And I'm going to introduce them briefly and then turn it over to the first one who will then introduce, just turn it over to the other folks. So our first speaker will be Chris Callahan. Chris is a physician and a professor at the Department of Medicine at Indiana University, and he's director of the Indiana University Center for Aging Research. Our next speaker is Elizabeth or Beth Gallick. She's a PhD and a certified registered nurse practitioner and associate professor at the School of Nursing at the University of Maryland, and a Robert Wood Johnson Nurse Faculty Scholar. And our final presenter will be Irene Moore, who's a Master's of Social Work and a licensed independent social worker, and a professor of family and community medicine at the University of Cincinnati College of Medicine. so with this interdisciplinary care team, I'm going to turn it over now to Chris, who can start our webinar series, our webinar today. Thank you.
Well, good morning or good afternoon to everyone, wherever you might be. I am still seeing the geriatric competent care slides, the opening slides. So have we moved through the other slides?
Yes, Chris, we're up to your slide at this point, the title slide with your name and the background and presentation of Alzheimer's disease.
Well, I'm going to switch over to a local version because I'm still on that title slide on my WebEx. But we're going to start this morning with a case study, and part of the reason for this case study is to bring this down to the level of our busy practices and the type of cases that we're trying to reach out in the community. But imagine that you have a 70-year-old man who's been brought into you by his daughter to see you for concerns that she has. There's a couple of things to point out here. First, maybe this is a widower. Maybe he's somebody that you've taken care of for many years. And maybe you're not used to him presenting with his daughter. Maybe even she lives out of town. And he says that he has no complaints and that he's feeling well. And maybe he wants to talk to you about a sporting event this morning. But his daughter's concerned because he's forgetting to take his medications, and he recently damaged his car when he was attempting to pull into his garage. We can switch to the next slide. The nature of this then, when you sit down and speak with the daughter, is that this has been a gradual progressive decline in short-term memory. She's noticed some decline in functioning as well. She had to help him with his taxes, and he's needed help with his bills, and he's been forgetting appointments, both doctor's appointments and other appointments he might have. And you do a physical exam and a mental status exam, and they're normal. Maybe his neurologic exam is normal also. But you do a mini mental status exam, and he scores a 22 out of 30, which is clearly abnormal for this man. Perhaps he has a high school or a college education. So in presenting here, one of the things that we'd like to accomplish with this webinar is discuss what you think is wrong with this patient, and is further testing required, and if so, what might that testing be? And then what guidance do we give the patient and the family? So first we're going to do some background definitions, give you kind of a mile-high look at the picture of dementia and cognitive impairment, and then we'll move on to some risk factors. But let's talk about background and definitions now. So the dementia is a decline in memory, and I think that's how many of us tend to think about it in shorthand. But remember that you also have to have impairment in another area of brain function, such as language or problem solving. And these have to be severe enough to affect a person's ability to perform everyday activities. Sometimes we might think of everyday activities as being only dressing and bathing and the kinds of activities of daily living we'd heard about, but we're concerned about, in our case example, someone that was paying the bills and can no longer pay the bills, or was able to drive safely and can no longer drive safely. So these might include instrumental activities of daily living. Often we hear about someone having difficulty managing their medications. A shorthand way to think about this is a decline in cognitive function from a prior level of functioning that's severe enough to impair social functioning. Dementia is caused by cell death, and that's one of the things that we like to be clear with patients as well as providers. There are neurons in the brain that stop functioning, they die, and when enough of them die, it begins to impair the person's daily functioning. And Alzheimer's disease is the most common form of dementia. We can go to the next slide. So this is a very important figure, and I'm going to take a minute to sort of let your eye adjust to it. So if you look on the y-axis, you see it's labeled normal and abnormal, and you can think about that as increasing levels of abnormality as you go up. And then across the x-axis, we have labels that say pre-symptomatic, early mild cognitive impairment, late mild cognitive impairment, and then dementia. Now, if you follow, for example, just the brown line, that's the one that's near the bottom. It doesn't curve up till very late, and it is abbreviated FXN, and it has an arrow to the brown line. That's what we see clinically. Clinically, we see people move through a pre-symptomatic phase, an early mild cognitive phase, a late mild cognitive phase, and we can barely measure any symptoms clinically. These are those older adults we're seeing in clinic that we're having a conversation with. They're not noticing anything, and we think they're fine. But if you look at any other of the colors on this graph, what you're seeing is that the damage in the brain and the pathology in the brain has been going on for many years. And so the dark green line that's labeled COG, that may be what we find if we actually test cognitive functioning formally. And you can see that we can begin to measure that if we test it formally, even if we're not able to see it routinely. If you look at the black line, the one that's near the top and that bends up the quickest, that is the levels of beta amyloid in the cerebrospinal fluid. So the point of this new concept is that Alzheimer's disease, by the time it's obvious to a clinician, has already done a great deal of damage. A second new concept, and this is the third bullet there, is that we said that Alzheimer's disease is the most common, but most people have mixed pathology. And the most common mixed pathology is vascular dementia. Moving on to the next slide, let's talk a little bit about these subtypes then. Now, these are a bit of a shorthand. These do work clinically, but with Alzheimer's disease, the patient typically presents with short-term memory loss being the most prominent symptom. With vascular dementia, we often see language impairment as a prominent symptom, as well as executive dysfunction. Executive dysfunction is our ability to plan. So each of us had to plan this morning to get this webinar on our calendar and to get on the phone or on the internet to participate, and maybe you needed to sign up for things, but this notion of imagining a future event and beginning to plan for it is what we typically mean by executive function. People with vascular dementia typically have vascular risk factors, hypertension, diabetes, cigarette smoking. With Lewy body dementia, often the most prominent symptom is not memory impairment, but things like motor impairment or hallucinations or visual spatial impairment. With frontotemporal dementia, this is one where you might have what appears to be a relatively preserved memory, but people have had a change in personality, and frequently the daughter would be presenting to you that her mother or her father had been uncharacteristically inappropriate in a social situation. Now, I give all of these typical presentations with a grain of salt because late in the course of a dementia, they all begin to run together, and any of these could be found late in a course of dementia. Mild cognitive impairment is a huge area of current research. Why? Because if you think about this and hearken back to that graph that we spent some time on, if we want to prevent cell death, we can't wait until a person presents with obvious evidence of dementia. The damage has already been done. So a lot of the research on interventions to prevent dementia or to delay it means we have to move up in that graph timeline into people with mild cognitive impairment. But we already said this is very difficult to discern clinically. What's the difference between mild cognitive impairment and a person with dementia? The number one difference is this person or their family might have subjective memory complaints, but you are not able to identify any functional impairment. They're paying their bills, they're not having accidents in the home, maybe they're using a lot of props, like they write themselves a lot of lists, but they're still functioning in their social environment. Now, I put a much more nuanced couple of sentences in the box here, but the bottom line of this is that this requires a lot of subjective interpretation by the clinician. We're not going to cover this today, but this is one of the reasons why people are hoping that we might come up with a practical neuroimaging test that would help you decide how far along the course of dementia any given individual was, even in that pre-symptomatic phase. So we can go to the next slide. Risk factors. Who's at risk for developing dementia? Age is by far and away the greatest risk factor. People over the age of 75 account for 8 out of 10 cases, and about a third of the people over the age of 80 have dementia. So think about this. Your number one risk factor for developing dementia is living a long life. So it is one of the consequences of a long life that you are at increasing risk of dementia. Other risk factors include low educational attainment. This is believed to be true because you may not have as much functional reserve. Family history of dementia, and cardiovascular morbidity because it puts you at risk for vascular dementia. And about 60% of people with Alzheimer's disease are women, presumably because they live longer. We're going to do a little bit more clinical epidemiology now. So there's about 5 million people who are already have dementia, and we expect about 15 million people with dementia will be around in the year 2050, and many more of them will have mild cognitive impairment. We like to point out when we're talking about these statistics that those 15 million people who are going to be living with dementia in 2050 are already here. They already survived childhood, they're already on the planet. So while this is a projection, unless these people die of something else, we will be taking care of this large group of people with dementia. It's the leading cause of, one of the leading causes of disability and excess healthcare costs worldwide. And people with dementia are going to live with it for about 5 years. Some people will live up to 10 years with dementia, and many of them will have comorbidities. And you can see the U.S. cost. Those costs that range into the hundreds of billions of dollars include the cost to informal caregivers. Well, one of the goals of this webinar is to help people in primary care be able to diagnose and manage older adults with dementia. But we recognize that this is complicated by a number of barriers. One of them is people with dementia typically have several other chronic conditions. They're often on 10 or more medications. And primary care is not really well designed or funded to identify and care for persons with dementia. Many of the best practice care are the models of care that we talk about will require practice redesign. And even that has upfront costs for the typical primary care practice. Next slide. Another interesting concept, because we talk so much about how many people there are with dementia, but the typical primary care patient or primary care provider has a panel of about 2,000 patients, but only about 300 of those 2,000 are older adults. And they already have to do a lot of work for those older adults. It's been estimated that we need 10 hours a day just to deliver the recommended care for people's hypertension and diabetes, and another 7 hours per day across this panel of patients to provide preventive services, things like pap smears and mammograms and teaching people to wear their seat belts. So now if you think about this from the primary care physician's perspective, there's only going to be 20 to 30 patients in their entire panel that'll have dementia. And we are asking them to make fairly large changes in their primary care practices to be able to attend to those 20 or 30 patients. Next slide. So let's talk about the principles of care. Again, we're going to go up to kind of a mile-high level. This is a journey, and this is how we often describe it to patients. It's going to unfold over 5 to 10 years, and the patients and the caregivers' needs are going to change over that time. Their goals of care are likely going to change over that time. And one of the things that we like to say to patients and their caregiver is that we are going to be with them on this journey, that we have covered this journey many times before, and begin to prepare them for what's right around the corner. A family caregiver is the fundamental foundation of longitudinal care for persons with AD. You'll hear more about that later. We like to organize our care around that dyad, and then we like to organize primary care around a team. This is a team that's going to help you take care of the dyad, but you can't really begin this journey, neither can your patient or the caregiver, unless you've made an accurate diagnosis and you've disclosed the diagnosis. So some statistics that the Alzheimer's Association has uncovered is that a large percentage of people never learn of the diagnosis even though their primary care physician may suspect it. Next slide. How might you redesign a practice? I've said this a couple of times. We already know that the U.S. Preventive Services Task Force does not recommend routine screening. That's because we have not had the research that demonstrates its risk and benefits. We do recommend case finding, however. Case finding means you test patients who have symptoms. So this older adult on our case that opened the talk this morning, that is not screening. That is not an asymptomatic person. That is a person with symptoms. And so when you do a mini-mental status on that person, you are doing case finding. So one way to reorganize your practice may be to do case finding during the Medicare wellness visit. Next. So if you use the Medicare wellness visit as an opportunity for case finding, what you would do is pick a case finding instrument that your practice is going to use consistently. You want to use it consistently because then you can all agree and you can set up the systems in your practice where this is the instrument we use, we all agree how to interpret it, and we all agree on next steps if that case finding instrument turns out to be positive. We also, though, need to develop a protocol for what happens when that case-finding instrument is positive. Case-finding instruments at best have a sensitivity and specificity of 80%. That means some people, even though they score poorly on this case-finding instrument, will be falsely labeled as demented. All that case-finding instrument is showing you is people who have cognitive impairment. So the evaluation needs to move on beyond that. You could do it yourself. in your own primary care practice, or you could refer out for it, but you need a plan. And that means you need to understand what's available in your community. And you need to remember that even if you refer this patient out, they're still your patient, and they still need care for their other ongoing chronic conditions and other care needs. Next. This slide has some of the resources that I've used to make these recommendations. Many of these I've put here because they're practical in a primary care physician's office. And we are going to hand the baton off now to Elizabeth Gallick, and she's going to talk to you about the assessment and diagnosis of dementia. And Dr. Gallick is going to go through a lot of the next steps in terms of the diagnostic assessment.
Thanks, Chris, and welcome everyone. I'm glad you're here today. So we're going to go to the next slide. Thank you. One of the first reasons why we're exploring the signs of cognitive impairment, one of them is to try to help to identify potentially treatable conditions that may mimic symptoms of dementia and Alzheimer's disease. So one of those being depression. When someone's depressed, they may have difficulty making decisions, difficulty concentrating, they may pay less attention to their appearance, and we might note a decline in their activities of daily living. Other things to consider could be a substance abuse issue or even different vitamin and mineral deficiencies such as vitamin B12. Hypothyroidism or a low thyroid level may also give some symptoms that are consistent with dementia in its presentation, with low energy, difficulty concentrating, etc., and also some mood symptoms. Normal pressure hydrocephalus is a condition that's treatable by placing a shunt in the brain. While it's rather uncommon, we do see it occasionally, and the common triad of symptoms includes a rapid onset of dementia and rapid progression, and profound urinary incontinence, and then a motor instability, so a gait instability or ataxia. Tumors may also give some signs of cognitive problems or even some psychotic symptoms like delusions or hallucinations, depending on where they may be located. And then one of the big treatable conditions which also can co-occur with a dementia is a delirium. So this is an acute change in someone's mental state, and they have kind of a waxing and waning of concentration, and it has some type of medical cause. And this could be a reaction to a medication, typically one that's affecting the central nervous system. It could be something like dehydration or an infection, hypoxia if someone's not getting enough oxygen, or an exacerbation of one of the chronic conditions. Next slide, please. So this is just a diagram that is comparing different characteristics of depression, dementia, and delirium. Because many times we know that even if someone has an underlying dementia, they may have some acute change in their mental state, which could mean a co-occurring delirium. So perhaps they're, have some certain deficits in their cognition, but then all of a sudden the family says, this person's dramatically worse, they're not sleeping well at night, they're groggy during the day, I'm not sure what's going on, they're having fluctuations in their level of consciousness. And again, it needs to move us back to looking at those medical causes. So looking at laboratory findings and considering the impact of medications. Next slide, please. The components of a diagnostic assessment include both a patient history, doing a careful physical examination, a functional assessment, and then a mental status exam with cognitive assessment, and then considering what additional diagnostic testing may be warranted. Next slide. In gathering the patient's history, you want to focus on 3 key areas. what has their cognition been like and what changes have been noticed recently? Have they been more forgetful? Are they having difficulty identifying people? Are these people that they're not as familiar with or individuals that they've known for a long time? Has there been changes in their ability to function? So is this a person who previously was able to manage their own medications and manage their own bills, and suddenly they're having more difficulty with that? They're going out to eat a lot more, and maybe they're not cooking for themselves as they used to. And then lastly, behavioral changes. So this is looking at some of the neuropsychiatric conditions and symptoms that can co-occur with dementia, things like depression or sleep disturbance or psychosis. The other thing that we want to consider is the onset and progression of symptoms. So getting families or some reliable informant to look back in time, and with the benefit of hindsight, when did things first begin? When did you first start noticing changes? And then how have the symptoms progressed? Has it been kind of a gradual change over time, or has it that we would typically see with Alzheimer's disease, or is it something where perhaps you're seeing sudden declines and then some stability, which may be more in line with a vascular dementia if someone had a series of strokes and then some decline afterwards? You also want to consider if there's been a family history of dementia. Did this happen in a first-degree relative, a parent, or a sibling? And what was the age of onset, and what was their progression in symptoms like? You want to do a patient interview and, again, get some sense of why does that patient believe he or she is there in your office or your clinic. I often hear, well, I'm not sure why I'm here. My daughter said I needed to come. Everything is fine. And so that way you're seeing signs of lack of insight into their condition, or can the patient specifically tell you some of the symptoms that they're experiencing? And then you also want to really have an informant come to the appointment to give feedback about how the individual has been doing. Next slide, please. We also want to do a thorough medical history, and if this has been a patient that you followed a while, you may have some of this information already, but really being careful in doing medication reconciliation. So have there been changes in this person's medications recently? Many people, although they may be followed in primary care, may see several different specialists, and it's often difficult to keep track of all of those things, so making sure that you're doing a good med rec when someone is coming in with those complaints of cognitive problems. You want to pay particular attention to anticholinergic medications, narcotics, psychotropic medications such as antidepressants, antipsychotics, benzodiazepines, any medication that acts on the central nervous system. The other thing you want to consider, have there been any recent falls or trauma, particularly to the head, that could indicate perhaps a subdural hematoma? Any other thing that you would want to consider to rule out an acute event? You also want to gather history about substance use, alcohol, drugs, caffeine intake, and then gathering some information about the individual's personal history. What's their educational level? Did they work outside of the home? What are their hobbies and interests? And importantly, and Irene will get to this later, what are their sources of social support? Next. There's some strategies that we can use for success when gathering this history, because if you've heard what was included in those two slides previously, you've probably thought, well, that's all well and good, but how can I possibly do this in the short amount of time I have to see patients? And one thing is to try to review some of their medical records in advance when possible. So if they're a new patient to you, getting those records in advance from them can be helpful. Looking at what tests they may have already had so that you're not repeating them. The other thing that a lot of practices are doing, especially now that we have electronic medical records, is getting some preliminary history from a caregiver prior to the appointment. So that can be done through them entering a secured computerized server and entering this information before the appointment, or filling out history paperwork in advance, or in some instances even talking to the caregiver on the telephone prior and having somebody in your office do that. And a team approach to care is often helpful. So you may have a medical assistant or a nurse who's getting history from the family while you may be examining the patient, or perhaps you're lucky enough to have a social worker in your office who is also getting some of that history about social support and things from the family while you're working with the patient. So having as many people involved in the assessment process can concurrently can make things go a little more quickly. Some warning signs of Alzheimer's disease when assessing patients. One is if they're coming in by themselves and they get confused about the appointment date or location. So perhaps you have someone who's coming into the office and they have an appointment tomorrow, but they're there early. Or if you have more than one office, they're going to the other office rather than the one where you've set the appointment. They may not be able to give you a very thorough history of recent events. Perhaps they've had a hospitalization recently and they can't tell you much about it. That could be a sign of dementia, or it also could be a sign of an acute delirium. You know, perhaps they had some type of operation with anesthesia while they were in the hospital, so you'd have to consider that. If they're coming in with a caregiver, another warning sign is when the patients are constantly deferring to the caregiver to answer the questions that you may have. And then also considering how the person presents in their appearance and behavior. Are you noticing signs of poor hygiene or inappropriate dressing? When you're conducting the physical exam, you want to do a careful one to try to identify or at least rule out any acute medical problems. But you're going to pay particular attention to both the neurologic and the musculoskeletal exam, particularly gait and balance, strength and reflexes. Is there any weakness or asymmetry which may indicate some type of stroke or other condition? In a functional assessment, you're going to incorporate this as part of your history taking, and again, ideally from a reliable informant, because someone with Alzheimer's disease may overestimate their functional abilities. You want to get information about self-care, such as activities of daily living, bathing, grooming, dressing, toileting, as well as instrumental activities of daily living, things like driving and shopping and managing finances, using the telephone. And you also want to, as I mentioned in the exam here, assess their gait, but getting information from a reliable informant about what their mobility is like in the home. Perhaps they come in with a walker, but at home you find out, you know, that's only when they go out of the house, they put that walker away, and the family may be concerned that the individual is unsteady. Some standardized rating scales to assess functional abilities can be helpful. The Barthel Index can be done with report of a reliable informant and looks at activities of daily living. The Lawton looks at instrumental activities of daily living, and again, ideally done with a reliable informant. And then the Get Up and Go is an example of really looking at somebody's mobility and balance, and can be done. It's a performance assessment and can be done in the office with the patient. The next component of your exam is going to be the mental status exam. And it includes several basic components that are really essential in diagnosing Alzheimer's disease, ruling out delirium, or considering other neurodegenerative syndromes. And there's several factors that can influence someone's performance in a mental status exam. The first being someone's educational level. They may have difficulty doing certain tasks if they have a lower educational level. So one of the exams that are commonly used is the mini mental status exam, and for someone to do serial 7s, counting backwards by 7s, may be difficult if they only have perhaps a 6th or 7th grade education. You also want to consider the individual's primary language. Is English their primary language, or is that a secondary language for them? Someone's ability to hear can also be critical in their performance. And so you want to make sure individuals have hearing aids and have their glasses if some of the things you're asking them to do require their vision. Next slide, please. So there's several components of the mental status exam, and we're going to go over each of them briefly. Next slide. So the first thing you want to look at is the person's level of consciousness, and this is really seeing if the person's awake, alert, are they kind of falling asleep during the time that you're examining them or interviewing them, is their attention not so good, so they're getting distracted by other things in the environment, or perhaps they're they are seeming overly stimulated or hypervigilant, and these are kind of signs that can help to potentially rule in a delirium, either a hyperactive delirium, or if someone's more lethargic, potentially a hypoactive delirium. We also want to look at someone's appearance and behavior, as I was talking before about appearance, but also their motor behavior. Is this someone that's fidgety, has a hard time sitting still, wants to try to leave the office? What kind of things are you seeing? Their speech and language, you want to see if they can spontaneously talk to you, or are they only just responding to your questions? Is there some hesitation in their response? Do they have difficulty finding words? Or is there a change in their rate, rhythm, and volume of speech? We want to assess somebody's mood, and many times if we ask older adults, how is your mood? Do you feel depressed? They'll often tell us no. But some other things that we can ask about are feelings of guilt or self-deprecation. Is this person saying a lot of negative things about themselves, like, oh, I don't want to put my daughter out, I'm really not worth all the time, they're so busy, and what's someone's outlook on the future? Things don't look so good for me. And then another key factor to consider is anhedonia, which is a lack of pleasure in usually pleasurable activities. So if someone is, let's say they always have liked, playing cards, but now they may not be engaged with that much anymore, they don't want to see their friends from their card game, that may be a sign of a potential depression. It may also be a sign that they're having trouble cognitively managing the game and want to remove themselves from that, but so you'd have to tease that out a little bit more. You want to consider if the person is having any psychotic symptoms, such as delusions, which are fixed false beliefs, or hallucinations, which are sensory experiences without stimulus. And then the last thing we're going to consider is some different ways you can assess cognition. Next slide. So for the cognitive exam, some things that you ideally would include would be memory, both delayed recall as well as immediate recall, and remote memory. So, what did you have for breakfast? Or even the longer-term memory, asking them something about, earlier in their life, or some historical events they could relate to from longer ago. You want to consider their orientation, to who's brought them, to the appointment, time and place. Looking at verbal fluency is another good way of assessing language ability. So getting people to tell you as many animals as they can in a minute to test their verbal fluency, and normally people should get somewhere between 15 to 20 in that time span. Items in a grocery store is another thing that you can do, and then with a phonemic cue, telling people, I want you to tell me as many words that begin with a letter S. And oftentimes people get a little fewer, less of them than they would with animals or grocery items, but that will but again, they should get somewhere between 12 and 15 in a minute. Looking at visual spatial abilities, you can have them draw intersecting pentagons, draw a three-dimensional cube. Clock drawing is another mechanism you can use. And then getting some understanding of their insight and judgment into their deficits or problem solving, giving them situations like, let's say, you were cooking an egg this morning for breakfast and the phone rang and you got distracted and there was a fire on the stove. What would you do? And then considering executive functioning, things like verbal trails or serial 7s or serial 3s. Next slide. So this is just an example of the mini-cog, which includes a 3-item recall as well as clock drawing test. And the pictorial designs here are showing you what you might see with someone with mild, moderate, and severe Alzheimer's disease when we ask them to draw the face of a clock and place the hands at 11:10. One of the advantages of the mini-cog is it's relatively easy to administer. It doesn't take much time, and anyone with, at least one error in recall or, some significant problems with their clock would need further evaluation. Next slide. This is just a list of some other cognitive assessment tools that you can consider. So there's links to the mini-cog as well as the Montreal Cognitive Assessment, also called the MOCA, the St. Louis University Mental Status Exam, or SLUMS, memory impairment screen, the MIS, and then the mini mental status exam. Again, it's been widely used, but now proprietary. Next slide. So then the last thing we're going to consider is further diagnostic testing. Laboratory studies, if they haven't had them recently, looking at a complete metabolic panel, a CBC, as well as looking at ruling out hypothyroidism or a thyroid disorder with a TSH, vitamin B12 and folate, and then depending on the history and the risk factors, you could also consider an RPR, which looking at for syphilis, HIV screen, even Lyme disease, again, depending on the history and exposure. And if you're concerned about some type of centralized inflammation, a sedimentation rate, or a CEA. And then you also want to consider brain imaging, either a CAT scan or an MRI, and matching that test with, what you're looking for. So an acute bleed, you may prefer a CT, or for an MRI, you may want to may be a little bit better in showing you smaller strokes. Next slide. So these are some future potential biomarkers for Alzheimer's disease. None of them are really commercially available. Most of them are just available in research because while they show promise, they're not 100% sensitive or specific, and they can be costly and as well invasive. Many of them require a lumbar puncture and can expose patients to additional risk. But as Dr. Callahan was mentioning, being able to identify people before they present clinical symptoms and potentially being able to help people plan for the future, or later if we have other treatments, the earlier we can identify people, it may help as more treatments become available. Next slide. And so now I'm going to turn it over to Irene Moore, our social work team member, and she's going to discuss communication of Alzheimer's disease diagnosis and caregiving concerns. Irene?
Yes, thank you, team.
Great.
Thank you, team.
Go ahead, Irene.
In thinking about communicating the diagnosis, there are several pearls that I enjoy. One is using open-ended statements, such as, I'd like for you to share with me. Please give me an example when you say your father is confused. Please describe. Using open-ended statements help us get to the second pearl I really like, which is starting where the patient is. We may think with all of the medical appointments and what caregivers have reviewed on television, the diagnosis may be clear, but in saying, I wonder if you had to give a diagnosis, what do you think it would be? And it's a good place to check because often family members have heard from the evaluation, well, at least there was good news, Daddy doesn't have Alzheimer's. This is just ordinary dementia. The history or cognitive screenings may be compatible or consistent with Alzheimer's to the clinician, but it may not still fit with the way the caregiver sees their family member. Despite years of working with older adults, I remind the family member, I just met your mother. You're really the authority on your mother. Maintain the caregiver as a vital team member. And in conversation, I always like to avoid saying why. I believe why is a term which leads to feelings of defensiveness. So think of this, please, as a conversation to avoid excess questioning and really going for the information you can really use. Further, keeping the focus on both the patient and the caregiver. Naturally, professionals focus comments and decision-making to the caregiver and sometimes stop talking to the identified patients. Some professionals like to sit in the order of themselves, the identified patient, and then the caregiver, keeping the patient in the middle and included. The importance of understanding the diagnosis is critical in developing a realistic plan. That plan is best established by health providers who establish transparency in getting to honest facts. A third clinical pearl I like is to help the caregiver plan for the exposure to working with a variety of professionals. Prepare the caregiver to keep a clear notebook and write down who they talked to, the date, and that person's number. Conflicting viewpoints may emerge, but this is how professionals at all levels may work to build trust in this preparation. And the caregiver may later say, oh, my doctor told me all this would happen. Prepare the caregiver for the fragmentation of care. Allow caregivers control in making decisions. Give empathetic help to identify and respect their choices. In supporting the caregiver, help to maximize their productivity and preserve their strengths. A wild goose chase or unprofessional handoff is really frustrating for caregivers, and it's a very poor use of their limited energy and patience and the time they've taken off work, and then directly displaces on their other life, their role as a parent, their role as an employee. Support the caregiver's advocacy for the patient. Think what works. Examine the creation of unfair service barriers care professionals, all of us, will come and go, but the family caregiver is the one consistent team member during the course of Alzheimer's disease for their loved one. So remember, the caregiver is crucial, constant source of history across time. Further in the communication and talking to the patient with Alzheimer's disease, obtain the patient's perspective of abilities, as with driving, for example. I'd like you to tell me how you drive. The response I often get is, I'll stop driving once I believe I'm no longer safe on the road. I'm safe, but most other people aren't. However, if there are unexplained dents on the car and the caregivers are concerned and the adult son will not allow his own young children to ride with the father, receiving this information from the family first helps to put a plan together and get the buy-in from the family first before approaching the older adult regarding discontinuing or modification of driving. And that's just one of many examples. What would real help be when what social workers recommend may not fit with the patient's perception of needed services? Think liberation, think smart, in-home creative technology, dignified digital sensors to basic grab bars, and the use of the old-fashioned gadgets like baby monitors really promote in-home safety. Clinicians have forms and paperwork that we want to complete, but does the patient know the reason for the assessment? As been mentioned by Beth, despite time restraints, always prepare the patient for the next step. Use reassurance and statements like, we're all in this together, you've been for an assessment, if something comes up which will be helpful, we'll know about it, we'll call you, your family is standing by, we have time to work this out, and a good plan for you. Remember to listen to the patient when discussing the diagnosis. Support for the caregivers, as we've heard, caregivers come in all shapes and sizes. And what we're increasingly seeing is the 95-year-old who is a primary caregiver for someone much younger. Sometimes that younger person is one of their own younger children. From my professional and personal experience, I believe the most cost-effective caregiver Alzheimer's intervention is to increase and empower support for the caregiver, because that's the cornerstone. Caregivers may be daughters, grandchildren, sons. It's important that if there's a family member who isn't available to provide direct caregiving support, there's still a lot of paperwork and there's still a lot of non-personal care that needs to be done. So it's important to delegate, but to give everyone participation in the care of the Alzheimer's individual, and always enhance the informal support network of friends, neighbors. Thinking of the care manager and Alzheimer's disease, the very fact that such a diverse audience is giving this much attention to this topic will make a compelling difference in the lives of caregivers and their family members. Remember, start where the patient and caregiver are, make specific interventions. Remember, not one size fits all. Use open-ended statements. For each patient, some help can always be given. Look for solutions and get help with the buy-in from the caregiver before presenting the information to the actual patient. Communicate very clearly that caregivers will be contacted to set up services by many, many callers. Caregivers, care managers will be the point person and the proactive person that's charged with setting up services. Reassure the family you're the contact person for further questions if this is true. If not, having a phone number of someone they can contact is worth its weight in gold, and the family will believe you've worked magic if you can help them have someone that they can contact, be it someone at an agency or the Alzheimer's Association. Avoid putting already stressed people through hoops. Why bother referring to services patients and families don't want? Help the caregiver honor old promises. I told her I'd never move her to a nursing home. Know what the patient and the family's wishes were so we can avoid trying to convince people to embrace a plan that only I, as the social worker, is thinking this is a good plan. Objectively look at the caregiver and patient's actual situation. Special considerations when working with families and caregivers: diversity, health literacy, and the previous relationship. These are just 3 items of an endless list. In focusing on the next slide for ethnic diversity may inhibit the caregiver's comfort in asking for clarification. A side effect will be the caregiving agreeing when in honesty they simply do not agree with the clinician, but may feel that it's disrespectful to do so. But transitions of care must include fundamental cultural expectations. For example, in the Hispanic or Asian community, the spokesperson may not be the actual decision maker for the family. It may not be the primary caregiver that you are talking to. It may be an adult child in another state that's the decision maker. So our charge is to think beyond the people we're seeing in front of us, but what brings their situation to the point that you're seeing, what's behind this. Health literacy in patients or caregivers, they may not ask questions in order to keep their lack of understanding private. Remember, the more confusing the choices are for us, the more confusing the choices are for the caregivers. Remember to use plain language and avoid jargon, which even saying we're going to give a CT scan, what is that? Or your father did a good job on the MOCA, what is that? Some older Hispanics, for example, don't read in Spanish. and many dual eligibles aren't online, but their children may be. The written information we share is often best at a 4th grade reading level. And also consider the previous relationship on the next slide between caregivers and the patient. An unexpected comment may be, my older sister was always mother's favorite, and now I'm the responsible caregiving one. Previous patterns and strategies for coping with trauma are direct predictors for how this family will deal with the Alzheimer's disease diagnosis. Understand bias, understand Alzheimer's disease, but more importantly, help them understand this in the context of their experience. Ask about the patient's, the family's family history of coping with Alzheimer's to look for Alzheimer's disease or late life memory problems. Assisting with caregiver responsibility, recognizing fear in terms of understanding the family. The fear of uncertainty for many families is their biggest burden to bear. Acknowledge this is new and unexpected. It's really unexpected for the Alzheimer's individual. This is not the way they plan to spend their retirement. And hearing this news is something that people must kindly hear more than once and in different ways. Caregivers need guidance to understand their situation. Health professionals often refer to caregivers as being in denial. I think that's such a coarse term. To me, I avoid that term. I really see this as bereavement. This is a loss. This is not the future that the caregiver or the patient had planned. And next, assisting with the caregiver response to the diagnosis, provide timely services and accurate resources. Anticipate that often when a caregiver isn't excited about the resources you've referred them to, it's really hard to relinquish even the most highly burdensome or difficult roles to someone else. Most caregivers still believe nobody can powder my mama's feet as good as I can. So relinquishing is very often very, very difficult and seen as a sign of you're inadequate. Your family member needs more than what you can actually provide. Assist the caregiver as the cornerstone in maintaining control of their lifestyle and personal environment. In looking at resources, every social service agency doesn't have a PCP in their office, but they need to know a PCP to refer to. And many PCP offices wish they had a nurse like Beth or a social worker in their office, but that may not be the case. But the PCP needs to know which agencies they can call on. And that network is really critical. The team that you develop may not be the team of 3 interprofessionals in the same office, but the team may be the Alzheimer's Association or that referral to elder locator. It sort of may be virtual or outside of your office, but we all need to have the network of who to refer to. We rely heavily on the Alzheimer's Association for their resources. Much of the information we've reviewed is also shared by the association, and the dementia resources are posted along with these resources for integrated care slides. In addition, we refer to the National Institute of Neurological Disorders and Stroke. So this has really been so much fun. I'm sure that Jesse is now ready to go forward with the questions. Thank you so much for including all of us, particularly social work.
And thank you, Irene, for your presentation, and Beth and Chris for yours as well. This has been incredibly informative, and thank you for joining us today. We do have a few minutes now for questions from the audience. I just wanted to make one or two announcements before. Regarding CME and CE credits, the post-test and evaluation will appear in a new browser window for all participants once the event is actually over, so once we close the WebEx. So first we'll do Q&A, and then that will appear for you in a new window. We do ask that you complete all questions in the post-test, and participants must receive a minimum of 80% on the post-test to qualify for credit. And then all questions on the evaluation must also be completed before clicking submit. If you're not seeking credit, we do encourage you to also complete the evaluation when it appears on your screen. And finally, a recording of this event, as well as all of the slides, will be available shortly at our website, www.resourcesforintegratedcare.com. At this time, if you have any questions for our speakers, please submit them using the Q&A on the right-hand side of your WebEx. Getting started, I have a question here that came in. Dr. Callahan, I believe you might be the best person to start this off. Do you have information and guidelines to differentiate between delirium and Alzheimer's disease?
Delirium, traditionally, we thought of as a much more acute problem. Some of this remains true, but the literature in and around delirium is changing, and I want to touch on that just a bit after I answer the question more directly. But delirium, the hallmark of delirium is an attention disorder. And we see that with someone who either has a fluctuating level of consciousness or maybe has incoherent or rambling speech. And probably the most available or widely known instrument to diagnose delirium is the CAM, or the Confusion Assessment Method. But I still think it's accurate to think about delirium as something that's happening in the hour and in the day, and there's an acute event that has precipitated it. Whereas dementia, as we've seen, is damage that's accumulating over many years. What makes it so difficult is that one of the greatest risk factors for delirium is an underlying dementia. That person with dementia is easily made delirious by simple things like a change in a medication or a urinary tract infection or maybe even commotion in the household. What's fascinating about delirium is that we used to think it was completely reversible. So if I treated the urinary tract infection, this older adult would have no lasting harm. And researchers are beginning to get worried that repeated episodes of delirium may actually do permanent harm. And so now we go full circle into thinking, well, maybe repeated episodes of delirium are a cause of dementia.
Great. Thank you, Dr. Callahan. Okay, I have another question here that has come in. Maybe Dr. Gallick, if you'd be able to field this. what kinds of things will clinical and healthcare professionals still be needed for in the next 10 years, assuming some advances?
Could you repeat the question? I'm sorry. What kind of things will healthcare professionals?
What kinds of things will clinical and healthcare professionals still be needed for, assuming healthcare advances in the next 10 years? So I guess we're looking at here, which direction do we think healthcare and clinical professionals will really be focusing on in the next 10 years?
So I guess the question surprised me a little bit, because I think healthcare professionals are really on the verge of having a large population of people with Alzheimer's disease and other dementias. You know, while research is promising, we have very few approved medications to kind of treat Alzheimer's, and those really are more just kind of symptomatic treatments. We don't have anything that really reverses the disease or halts it. So, you know, I think that we're all going to be busier rather than not. And, you know, in terms of assessing patients, resourcing families, and it really is going to take an interdisciplinary team and all of us really working together for the betterment of the patient and the family. So, I mean, I think we're going to have plenty to do.
Great. Thank you, Dr. Galick. I have another question here. I think this might be directed at you, Irene Moore. When patients have poor insight into their memory loss and do poorly on cognitive tests and basically have not been functioning as well according to their family, how do we get these patients to buy into the fact that they have dementia and that they do in fact need help?
That's an excellent question. This is a very patient-specific. The person's premorbid personality, if they were very easy to get along with in their 30s, that certainly helps in late life if they have dementia. But what is it that that person responds to? If it's stopping driving, I don't think it's always necessary to go through the facts of why you aren't able to drive, but in talking to the person about first their perception, often people think they're capable, but often they are concerned, and often they feel really relieved when driving stops. But putting it in context of the insurance is getting too expensive, often people disable a car, bringing it to reasons that are face-saving for the individual without exactly confronting the facts. As long as the family is aware of the facts and the need for intervention, be it terminating driving or the utilization of community resources or going for an evaluation. It's sort of take all things by the smooth handle, and the more relaxed the family, the caregiver is in talking to the person, the better. But once there is a feeling of anxiety or irritation, then the Alzheimer's individual often feels that, and it becomes an impossible situation. So there's not one way to do it, but I think playing to the emotion of what that person liked and doing it as matter of fact as you can.
Thank you. I mean, that's very helpful. The next question we have here is specifically to Chris Callahan. What would Dr. Callahan state as future medical principles for physicians to follow for diagnosing as well as treating families?
I think there are some readily available principles. One is that you've heard over and over again in the webinar is that you are working with a dyad. You're working with a family caregiver and you're working with the patient. That principle, so many things fall from that in terms of the design and the day-to-day operation of your clinic and the way that you receive patients. We will still have in this day and age that daughter that we talked about in the opening case prevented from joining her father back in the exam room. Sometimes people will use excuses like privacy and confidentiality. They'll use excuses like there's not enough room in the exam room, but this principle that you're working with a family caregiver for a patient with dementia, many day-to-day routine tasks are going to fall from that. The second is, and we've tried to embody it in this webinar, is that this is not a job that rests on the shoulders of a physician. We need help from other people. I can assure you that if I sat down with the family and then said, would you rather sit here and talk to me for half an hour or Irene Moore, 8 out of 10 of them are going to want to sit down with Irene Moore. It's a reality of our different skill sets and how patients and families view our skill sets. It's going to be the same with the different skill sets between me and Dr. Gallick, or maybe you're lucky enough to have a pharmacist in your clinic. So that second principle is a team-based approach to care. If I had one more, it was already alluded to by Irene, and that is every one of these patients is different. Every one of the caregivers is different. And now add in this sort of like real complexity that their relationship is different. So when I say we're working with a dyad, that's two unique individuals who have a unique relationship, and a lot of your work with that dyad is going to be probing and listening and trying to understand where you can reach this team to get to their goals of care, so that tailoring or individuality I think is extremely important as well. Those are not principles that fit neatly into the way we take care of a lot of chronic conditions, but I think the more we use them and see how they work, I think you're going to find out they work pretty well for hypertension and diabetes also.
Thank you very much. We are getting a lot of great questions coming in through the Q&A, so thank you to all of our participants today. I think we have time for just one more, and I'm going to try to put two questions that are similar here together, and maybe Dr. Beth Gallick, you could take a start at this, and feel free to pass it to Irene Moore. So these questions are concerning people who are showing early stages, early signs of dementia, and who don't really have many supports. They might have home care services and are lacking in close caregivers and even live alone. So what could you recommend for patients like this?
So that's something that I think we're seeing more and more in terms of our society, where more people are living alone, and as families are smaller, there may not be an involved child, or the person, you know, may not have a long-term relationship with someone that they lived with, or the child may live further away. So the first hurdle really to get over is trying to get an accurate history with that individual, and because they may be able to tell you some things, but again may overestimate their ability to function. So some things that you can do is, one, seeing the patient, if your practice has the ability to do this, to do a home safety assessment, or even to order this from one of your occupational therapy consultants. So to actually go into the home and see what's going on, you'll get a lot more information that way. And in general, there often is someone who can help and serve as an informant. One time I had a woman that I cared for who had two sons who were involved but knew very little about her day-to-day living and experiences and what she was doing functionally, because she was kind of private with them, but yet she was in walking distance to her local pharmacy and was quite fond of the pharmacist there and would go and visit him every day almost. And so in that instance, he became one of my more valuable informants to tell me what was going on with her. So we have to kind of get beyond, you know, where we're thinking in terms of family. Also, if someone's having early signs of problems, getting them to think about who they would want to make medical decisions for them if they were unable. And so this gets into our durable medical powers of attorney, so helping people, you know, work through that process and think about who they may want to do that. And, you know, Irene, any other comments you know have to that? I know geriatric care managers can also be quite helpful.
And sometimes there are multiple children who are not involved participants in care. So in many ways that's quite sad when there are family members, but due to estranged relationships or so forth. But most people have someone, as best example with the pharmacist, that is highly on the informal network, who is aware and can act as a reliable informant. You would think ahead to situations like pro-seniors or having a payee set up for perhaps their Social Security. When someone's starting to have a problem, often they become an unfortunate target for exploitation. So it really is critical to ensure their safety and realize it's not one size fits all.
Mm-hmm. Thank you, Irene and Beth. That was very interesting. And thank you for this discussion and the presentation today. We're just winding down now, so I just wanted to remind everyone one last time that if you're seeking CME or CE credits, both the post-test and evaluation will appear in one new internet browser window once we close the WebEx, and we do ask that you complete all of the questions on there. If you have any questions or comments about the CME CE credits or anything that you saw today, please don't hesitate to email rick@lewin.com. That's RIC@LEWIN.com. Again, the slides for today's presentation, a recording, and the transcript will be available at the Resources for Integrated Care.com website shortly. Thanks again to all of our speakers, to Carol Reagan from Community Catalyst, and particularly to all the participants today. We hope you have a wonderful afternoon, and thank you for your participation.